My name is Emily Welch, and I will be presenting on an ostium primum atrial septal defect in an adult. My patient is a 51-year-old African American male. He presented to the emergency department complaining of generalized weakness. The patient also reports having a stroke 2 to 3 weeks prior to this visit. He has a history of hypertension, congestive heart failure, and chronic obstructive pulmonary disease, or COPD. The patient said he was diagnosed with an ASD or atrial septal defect in early childhood, but did not receive any follow-up or treatment for it. The labs that we look at before any echocardiogram are BNP and troponin. My patient's BNP was slightly elevated, but his troponin was normal. An elevated BNP indicates heart failure, and elevated troponin indicates heart damage. Figure 1 is an apical 4-chamber view cine clip. This clip shows the large defect in the interatrial septum. Figure 2 is a still image of the apical 4-chamber view of the heart at the end of systole. You can see in this view that the right side of the heart is severely dilated and that there is left ventricular hypertrophy. Figure 3 is an apical 4-chamber view with color Doppler demonstrating a left-to-right shunt through the defect. This left-to-right shunt is what is causing the dilatation of the right side of the heart. There is also transient right-to-left shunting with respiration noted in this patient. Figure 4 is a cine clip of the apical 4-chamber view. This cine clip is using a split screen tool to show the grayscale cine clip on the left and the color Doppler cine clip on the right. My patient's diagnosis is an ostium primum atrial septal defect, or ASD. During embryonic development, the interatrial septum has two components, the septum secundum and the septum primum. The septum primum grows downwards and fuses with the endocardial cushions, and the septum secundum grows down from the top of the atrium and fuses with the septum primum to make one interatrial septum. Ostium primum ASDs result from the failure of the septum primum to grow down and fuse with the endocardial cushions. Atrial septal defects are one of the most common congenital heart defects, but the ostium primum ASD is one of the less common types of ASDs. Ostium primum ASDs are associated with chromosomal abnormalities like Down syndrome and Turner syndrome. They are also associated with maternal teratogen exposure like rubella or drugs such as cocaine and alcohol. Maternal diabetes or autoimmune diseases like lupus also put a baby at a risk for developing an ASD. Clinically, the patient may present with shortness of breath, worsening with exercise. They may also present with fatigue, congestive heart failure, palpitations, a murmur, and a history of a stroke. Some complications of an ostium primum ASD include increased risk of a stroke, arrhythmias, congestive heart failure, pulmonary hypertension, and a shortened lifespan. On ultrasound, you will see a defect in the apical portion of the interatrial septum. However, the ventricular septum is intact and the atrioventricular valves are completely separated. There will be a left-to-right shunt in smaller defects or a bidirectional in larger defects, like my patient's. Mitral valve clefting is an associated lesion, but it was difficult to determine if there is one in my patient's case due to the off-axis orientation of his heart in the thorax. A mitral valve cleft is best seen in the peristernal short axis and is most commonly in the anterior leaflet. An atrioventricular canal defect, or AVCD, is a more extreme congenital malformation in which there is a single atrioventricular valve due to the ostium primum ASD and a defect in the ventricular septum. The key in differentiating an ostium primum ASD from a complete AVCD is visualizing separated atrioventricular valves. An AVCD results in equal pressures on both sides of the heart, where in normal situations the pressure should be higher on the left side than the right. A complete AVCD has many of the same manifestations of an ostium primum ASD, such as congestive heart failure, shortness of breath, palpitations, murmurs, and a stroke. Our patient was referred to a cardiologist and a neurologist and was discharged. Surgical correction usually is required with osteoprimum ASDs. Open heart surgery is the only way to correct osteoprimum ASDs, and the surgeon uses a patch to close the defect. In conclusion, my patient was a 51-year-old African American male presenting to the emergency department with a chief complaint of generalized weakness. He stated he had been diagnosed with an atrial septal defect in early childhood but never received follow-up for it or treatment. He had a stroke 2 to 3 weeks before his visit to the emergency department. His diagnosis is an osteoprimum atrial septal defect. One pitfall that we encountered is that due to the off-axis orientation of our patient's heart, a parasternal short-axis view was not obtainable. In patients with osteoprimum ASDs, it's important to get a good visualization of the heart and parasternal short-axis view to view the mitral valve, because mitral valve clefting is a commonly associated lesion with osteoprimum ASDs. A teachable moment is don't be afraid to ask for help. We actually got another sonographer to come look at this exam to be sure we had all the images we needed. She recommended the split-screen cine clip that I showed you earlier. The cardiologist actually complimented the sonographer on this exam and said that she did a great job at documenting this pathology. And here are my references.